Good afternoon, remote attendees. We will be getting the meeting started in about 5 minutes. We are waiting for one more member for a quorum.
I'd like to call a meeting, Quality and Patient Safety Committee to order. Apologies, Mr. Knight. Will the Secretary please call the roll?
Yes. We have a substitute filling in for Director Webster Cross. Director Harrington?
Present.
Director Kim? Present. Director Sorrell?
Present. And Director Mia Cross is online.
Right. We can only have 5 members voting at a meeting because
Oh, sorry.
opposed to 5. So since we have one substitute, I'm sorry, it's the odd math. And Director Staines?
Yes, here.
Director Webster Cross?
Present.
Chair Bott?
Present.
And Ms. Merriweather?
Present.
You have a quorum.
Thank you, Secretary. The next regular meeting of the committee is scheduled to be held on Friday, November 14th at 9 a.m. I'd like to entertain a motion to allow Director Stearns and Director Sorrell to remotely participate in this meeting as voting members. So moved. Motion has been made and seconded. Is there any discussion on the motion? All in favor say aye.
Aye. Aye.
All opposed? Chair, ayes have it, the motion carries. First item on today's agenda is public testimony. As a reminder, written testimony will not be read on the record, but will be included in the official record of this meeting and posted on the website. Madam Secretary, do we have speakers who registered to provide in-person or virtual oral testimony or submitted written testimony?
We did not have any registered speakers nor any written testimony submitted. And if I could clarify just regarding Director Webster Cross, she is marked in as a member who is present. She's just, due to the voting aspect of it, she's just a non-voting member for today, but she is present.
Thank you, Madam Secretary, and thank you for being here, Director Webster Cross. Next item on today's agenda are proposed Georgia Hospital Division Chair initial appointment, 3 appointments to be reviewed by Dr. Kamapwe, Medical Director, Georgia Hospital.
Good morning, Chair Barton.
Good morning.
I respectfully request approval for the appointment of 4 physician division chairs of the medical staff of Georgia Hospital for 2-year terms ranging from October 1st, 2025 to October 1st, 2027. The first 3 presentations will be for reappointments, and the last will be an initial appointment. Dr. Sean Conway is being reappointed to the position of Chair of the Division of Adult Outpatient Psychology. He first joined Cook County Health in June 2024 in this same role. Dr. Tom Loeb is being reappointed as the Chair of the Division of Pediatric Surgery. He joined Cook County Health 7 years ago as the Chair of Pediatric Surgery. And the last reappointment is Dr. Fred Starr, Chair of the Division of Trauma Administration. He joined Cook County Health in July 2004 and was appointed Division Chair in 2014. Dr. Deepti Digi is being initially appointed as the Chair of the Division of Pediatric Hematology Oncology. She did her medical training in India and did her residency with us and did her pediatric fellowship training at the University of Chicago's Coma Children's Hospital. She first joined Cook County Health in 2012 and was just named the division chair this year. Thank you. I'll entertain any questions.
Thank you. I'd like to entertain a motion to approve item 3A, 1 proposed Georgia Hospital Division Chair initial appointment, and 3 proposed Georgia Hospital Division Chair reappointments. So moved.
Second.
Motion been made and seconded. Any discussion on the motion? All in favor say aye.
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 Opposed? Ayes have it. Motion carries. Thank you, Dr. Kamapwe. Dr. Allegretti, President of the Providence Hospital Medical Executive Committee, will now provide any reports and will present the medical staff action items for the committee's consideration and approval.
Hello, good morning, everyone.
Good morning.
The Unified Credentials Committee met at the end of September and approved the items which you received on document. The MedExec Committee at Providence approved this on October 3rd, and I'm here to ask for your approval. I'm here if you have any questions or comments.
Any questions, comments?
Thank you.
Thank you. Dr. Tom Pachinakos, President of the Stroger Hospital Executive Medical Staff, is unable to join us today. He is out conference, but the Stroger Medical Staff action items sent in advance and are being presented for your consideration. Any questions or comments? I'd like to entertain a motion to approve item 3B, Stroger Hospital and Providence Hospital Medical Staff appointments, reappointments, and changes.
So moved.
Second.
Motion been made and seconded. Any discussion on the motion? All in favor?
Aye.
All opposed? Motion carries. Ayes have it. The next item is September 19th committee meeting minutes. These were approved at the September board meeting, but are being presented for any further edits or corrections if needed. Directors, any corrections need to be made to the minutes? Okay. I'd like to entertain a motion to accept item 3C, September 19, 2025 meeting minutes of the Quality and Patient Safety Committee.
So moved.
Second.
Motion has been made and seconded. Any discussion on the motion? All in favor, say aye.
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 All opposed? I was waiting for those online. All right. Motion's been made and seconded. Ayes have it. We'll go to the next item. The next item is a review of the OpEx dashboard goals and tactics by Donna Austin, Kathy, Dr. Arnold Turner, Dr. Sharon Iron. Thank you so much. All right.
Thank you.
Yeah.
Thank you, Chair Bott. So first off, starting with the OpEx committee dashboard, just high level, 3 of our metrics have met the stretch goals thus far in nursing communication domain, post-hospital follow-up, and our COPD rate. 3 of the metrics are hitting the target, our provider communication domain, geometric length of stay, our ED length of stay, and our ED length of stay for the ED discharge patients. 1 metric is better than our baseline patient safety indicator, our PSI 90, and 2 are still in review and are not meeting the target currently, sepsis and mortality index, which we'll talk a little bit more about. Next slide, please. Next slide. Oh, thank you. Okay. Looking deeper into our OpEx dashboard, first, when we're looking at our provider communication, the rolling 12-month is still at the goal, coming in at September 2025 at 85.30 top box, and our September 2025 had a lower top box at 78.4. So our year-to-date is currently better than our baseline and very close to our goal of the 85. Nursing communication, again, continuing to do an outstanding job. Rolling 12 months, still above the stretch goal of 76.14 top box. The year-to-date is better than the stretch goal of 75.29. And September 2025 came in a little lower. We're certainly continuing to watch that, but year-to-date, we're exceeding the stretch goal. When we look at our clinical outcomes, mortality index, the rolling 12 months, September 2025, came in at 0.99, which is less than the 1.0 index. We are continuing to look at that. There's a significant amount of work being done by Dr. Radigan. Remember, I spoke several meetings ago about the mortality committee that was currently launched in 2025. As of September, they're continuing to do deep dives into the the deaths. They are currently pre-reviewed by our physician and our nursing leads. 3 to 5 of the high-yield cases are identified each month, and they're focused on the multidisciplinary discussion. And also, nursing leaders are fully integrated in expanding their role. When we look at our patient, moving on to our patient safety indicator, the rolling 12-month September 2025 came in better than the baseline of 0.96, less than the 1.0 index, and August 2025 came in at 0.82 PSI composite, which is at the target. Looking at our sepsis bundle compliance, the rolling 12-month September 2025 came in at 41.9, and the monthly at 2025 came in at 45.83. So these currently, the sepsis committee is still in progress, and there's a lot of rapid improvement being looked at and done in the committee. The emergency department has been a focus, and majority of the sepsis cases originate in the emergency department, and there's a rapid improvement event that is scheduled for later this month, October 31st. Also, there's an HIS optimization plan being reviewed, which is going to look at revising the fluid orders that are set for the CMS compliance. And also, the team is currently reviewing the workflow advancements and also technology advancements. When we look at the moving into our readmissions, the post-hospital follow-up, currently September at this time is in review. And also last month we talked about the August 2025 is currently exceeding the stretch target of 20. The COPD, the rolling 12 months, July of 2025, came in at 12.08, while our monthly rate is at 21.43 for July. And we have seen some dip in the from the baseline. And so under review with Dr. Ahmed and Dr. Jabbar, they currently are working through the COPD committee initiatives that include developing the standardized COPD action plan. They've implemented the lung health educator-led teachings. They've also improved access to the smoking cessation clinic, and there's ongoing efforts to improve the QUIT-A prescriptions. Also, the group has done a breakdown of the 11 audited readmissions, and so they currently continue to review those. Moving into the throughput, the rolling 12 months still is meeting the goal at 1.44 average days variance to our geometric length of stay. The monthly result for August was slightly higher at 1.60. Also, in our ED length of stay for ED discharge patients, our rolling 12-month median for ED length of stay for ED discharges is at 293 minutes, which is meeting the goal. The last 2 months were a little higher as we had higher volume in July and August at Stroger. Currently, year to date, we are meeting the goal of 303 minutes. Well, the goal is 324, and we're currently at 303 minutes.
On the mortality index, was there a comparison of what may have been different between going from April to, it looks like February through April, things that were working well, or things that might have impacted that number between April and August? I think you alluded to fluid orders and training, rapid improvement.
So the fluid orders were sepsis.
Okay.
So your question about the mortality?
Yeah, it's about the mortality.
Yeah, so there's been a complete revamping under Dr. Radigan that started really in July of the committee. So they established the mortality committee. which is now fully functional and multidisciplinary. They have now transitioned to a single reviewer format, where 100% of the deaths are reviewed, as well as 3 to 5 high-yield cases are identified each month for focus and review with a multidisciplinary discussion team.
Okay. Any questions, comments from directors online or here? Okay, we'll keep going. Thank you. Thanks for the continued work on these topics. Dr. Turner, Provident Hospital site, and we'll go to ACHN.
Excuse me. Thank you, Dr. Bott.
Thank you.
Good morning, directors.
Good morning.
I'm going to present the Provident OPEX Committee dashboard. Just as an overview, we're meeting the stretch goal with one of our metrics, that's for falls. 2 of our targets, left without being seen, and ED decision to admit to ED depart, are at target. 2 other metrics, sepsis and nursing communication, are better than baseline. And 1, we're still not meeting the target, and that's with the patient experience survey return. Next slide, please. I'm going to look at the metrics in more detail. Now, the first one is the patient survey return. We've put a number of things in place to try to improve this, including follow-up phone calls after discharge as part of the discharge instructions. It's also, we've added tabletop tents in the rooms to remind patients to complete the surveys, and we also, in the discharge packet, there's a flyer, and on our hallway monitors, there's a slide that also encourages patients to complete those surveys. But despite that, still have not been able to get that to move toward our target, although I understand we are going to be moving to an email survey. Hopefully that will show some improvement, I think. Because currently we just use mail, which is kind of fallen out of favor, I believe. The next one is nursing communication. As you can see, we continue to be above baseline for last year with the rolling 12-month average approaching the goal of 80. Our monthly response for September was actually a little lower than what it had been because we have been at 100%. Part of the problem is that we have such few surveys returned that can really impact the results of that. The next metric is the rolling 12 months of sepsis. We remain above target, but above baseline, but not at target. We did have 100%, but we have a low volume of these cases that present to our ED, and that also affects. But there is a sepsis task force at Stroger that Provident will be partaking in and making some changes to see if we can still move the needle on the few cases that we have. The next metric is the inpatient falls. We continue to do quite well in that, as you see, with the rolling 12 months being below the goal of 16. And our month for August, we're at 14, which is below the stretch goal. So we're continuing to, this was accomplished by a number of efforts by our nursing department, by establishing fall rooms, hourly rounds, decreasing the response time to call light, and making sure all the patients have the fall packs in the room, which includes the slippers, things like that. The next metric is the left without being seen. We continue to meet the target, below the target of 2%, and that approaching the stretch goal of 1%. We have done that in some months, and hopefully we'll be able to bring the rolling 12 months down below the stretch goal. That was the next, the one above that was the rolling 12-month meeting ED admits decision to depart, and we're at the targets, meeting the target for that at 104 minutes. Target is less than 120 minutes, and we're still hoping, and as we have done in some months, been below the stretch target of 100 minutes. We're working to make sure we maintain that in the near future. Any questions? Thank you.
Thank you. Dr. Charnay? Great. ECHN site review.
Good afternoon, directors. I'm Sharon Irons, the Medical Director of Ambulatory Services, and I'm presenting for Craig Williams today. So we will start with what's on the top row here, which is the patient experience data. There are 3 indicators which we follow, and the 3 are most closely mirrored with the likelihood for patients to recommend us for care. So number 1 here on the top is how well staff work together. Number 2 is providers addressing concerns or worries. And number 3, providers explaining to patients their problems and or conditions. So again, we look and focus on the top box score because obviously it's a well-utilized metric for this. If you look, the gray bars are the rolling 12-month data and the blue is monthly data. So again, if you look across the year, 2025, there's been some up and down, but overall we are improving. If you look at the last month for all 3 of these indicators, we are exceeding the stretch on 2, and 1 is meeting the goal. We attribute this to us doing better staff education, incorporating improvement discussions at all of our local staff meetings at the clinics, creating forums for feedback, recognizing employees who do well, and pointing out instances when individuals go above and beyond. And we more recently developed some workshops we call Thriving Together, where the ambulatory leaders meet with the frontline staff and providers and provide an opportunity for them to give us feedback. And last week we did our first 4 workshops, and we've had 25% of our workforce show up for this, so those are some really good numbers. And I'm going to skip down to the bottom and talk a little bit about other metrics that we follow closely, including our HEDIS metrics. You have the first one here at the bottom is going to be your breast screening rates. And second one is controlling high blood pressure and how we manage hypertension in the ambulatory setting. And then finally, this last box, bottom row, is about empanelment, important metric to follow for primary care. So going back to the breast screening, we look at women age 40 to 75 who've had a mammogram within the previous 2 years. And this is a question that Director Bott asked me last time, and I promised I would bring it back. So what we've been doing, and the reason the numbers are so good, is we've been opening Saturdays and evenings and extending additional access to our patients. This started in February of this year, 2025. And what you wanted me to look at, Director Bott, is the slot utilization. How well are these slots being filled? So what we found is that anywhere between 95 to 100% of those Saturday slots are being filled, but lesser so for the evening. And the evening slots are between 4 to 8 p.m. And we're finding when we first started this that almost 100%, but now we're down to 50%. So it seems that patients are not preferring evenings as much as they do Saturdays. So one thing that the mammography department is looking at is perhaps instead of going from 4 to 8 p.m. in the evenings, that might be truncated to 4 to 6 or 4 to 6:30 p.m. The show rate overall is about the same, whether it's evening, whether it's Saturday, or during the day, 8 to 4, we have a show rate of about 70%. I'm going to go next to hypertension, controlling blood pressure, meaning that patients in primary care have blood pressures controlled to less than 140/90. We attribute our success here, again, we're doing very well, to a quality improvement program that we have, and we've been partnering with the American Medical Association for several years now. We call it the MAP program, which is M stands for Measure Accurately, A for Act Rapidly, and P for Partnering with Patients. We just recently received another Silver American Heart Association Target Blood Pressure Award, and we were honored because of our quality improvement and how well we're doing with having our medical assistants and our nurses measure blood pressures when patients are in the clinic. And there are some, thank you. I'm going to now turn our attention to empanelment, which is this last box again, and that's really how many patients we provide primary care for within the ambulatory network. We have engaged patients, which are patients that we have seen at least 2 times in the last 2 years, and affiliated at least once during that period. So how are we doing, how are we working with this? It is improving. We haven't yet met our goal, but we are increasing access to the number of new slots. Our goal was, we started with a baseline of 87% of our new slots being filled for primary care. We targeted 92% by the end of this year, and we are now currently at 93% of those slots being utilized. And of course, we want to get to 100%. And obviously also looking at enhanced recruitment efforts in primary care, creating pipelines for our residency programs, including physician residency, as well as we now have APP residency here for primary care. So we are really actively trying to recruit from those programs. And I have been successful in doing so already, especially for the APP fellowship program. Next slide, please.
Before we go on?
Yes, Director.
Yeah, I have a question. And again, I want to applaud you for your work in breast cancer screening and the increase in hypertension management. Those to be applauded, as we just did. And
thank you.
I want to commend you and your team for doing that. When I look at the charts above, everything seems to improve, and then there's a drop, and then it goes back up, and then there's a drop, and it goes back up. So it seems like this is cyclical. Is there any explanation for why we get to a point where we exceed the goal, then we drop, and I guess you're doing training, but it seems like there's some inconsistency somewhere in here. Okay,
and you're looking at the top row for the patient experience, yes, Director. Right. Yeah, that's a great point. I was actually looking at that myself. It is up and down in terms of how patients are rating us. And I would like to delve into that a little further because it may have to do with the number of patients being surveyed. I'm just not 100% clear on why the up and down, but I will look into that further and get back with you on that.
Yeah, I had a similar question, Director Harrington, so thank you for asking that, and I'm interested in that as well. And I just thank you for the follow-up on breast cancer screening, and congratulations on the progress on those items.
Thank you.
Director Harrington.
I do also want to add that we are hiring a manager for patient experience for her to dive in. She actually has some experience she worked at MedLight in New York and managed 30 clinics for patient experience. So we're hoping that when she starts on November 3rd, she'll be able to help with the consistency of the patient experience, because right now we don't have a designated patient experience person.
It'd be interesting to remind us 6 months from now and see if there's been a change. We won't remember that in 6 months.
Thank you.
Thank you. Yeah, I think it points to the importance of systems and sustainability and high reliability, which is some of the work that quality and safety teams are and the system is doing.
Okay. And did you have any additional questions on this? I was going to go ahead to the dashboard here. Okay, so we'll
Is
back
there a
one
question?
slide, please.
Is there anything online? Okay. Sorry,
None
go
at
ahead.
this time.
No problem. So,
None at this time, thank you.
Thank you.
okay.
Go for it.
We're having an interesting time here. This is the correct slide. Thank you. Okay, so this is the dashboard, and it just kind of drills a little bit more into the information that we saw on the other slide. But I'm just going to start at the top here. Staff working together, our baseline for that was in 65.66%. Target being 68.08 and stretch 69.78. Our rolling 12 months is 67.06, showing continued improvement, not yet meeting the goal. But last month, September, we really actually exceeded the target. And so it exceeded the target and the stretch for 70.68% on that top box score. For provider addressing concerns and worries, 65.62% baseline, target of 67.54%, stretch 69.13. Our rolling 12 months was 67.05, again showing continued improvement, not yet meeting the target. But if you look at September, which we really did well last month, 69.06, so definitely meeting the target, almost at the stretch goal. And then provider explaining problems and conditions, baseline 64.47%, target 66.39, stretch 68.36, rolling 12 months 67.48, so meeting the target. And then in September last month, 69.02, exceeding the stretch goal. Looking at our HEDIS metrics, our breast screening, and I just want to say we are doing a phenomenal job with breast screening. Our baseline was 53.3% at the very beginning of this year, so we targeted 55% with a stretch of 58.4%. Our rolling 12 months is currently at 62.8%, so we are exceeding the stretch target. Blood pressure control or hypertension management, baseline, again, we're doing really great here. And to put this into context, at the beginning of the pandemic in 2020, our blood pressure control rate in this system was 32%. Today, we've had a baseline of 55% at the beginning of the year, a target of 57% control, a stretch of 61%, and we're now at a rolling 12 months of 59.6%. I will now talk about impanelment. That's our last one. Our baseline is to have, or was to have, 116,157 patients impaneled to us at the beginning of the year. Our target was to increase by 2.5%. To 119,061 patients, and with a stretch of 122,000. And our rolling 12 months shows improvement. Haven't quite met the goal yet, but we're at 118,026. That is the last metric.
Thank you for the report and the continued work on these areas. All seem like they're consistent, positive movement, good direction, so thanks for the hard work. Any questions from directors here or online?
Not a question, but just
Comment?
an observation. Yeah. It's really interesting when I look at these last three and I look at the improvement. Really, it talks about, in essence, the term engagement. It's something that you've done that gets patients engaged, because people have to keep their appointments to do these things. They have to be taking their medicine to do these things. So I don't know what the magic is, but there's something that you've done that's gotten patients to be more compliant, and I want to applaud you for that.
Yeah, well, it takes a village. So the teams are completely engaged with this quality improvement. The nursing, the MAs, the providers, the whole 9 yards, and even the patients, doing more education with them. So we're just going to keep pushing ahead. Thank you. Okay.
All right, well, next item is the quarterly grievance and patient experience report, reviewed by Monday, Chief Experience Officer. Thank you.
Thank you. Good afternoon. As a reminder, starting fall 2025, CMS requires all hospitals to report grievance resolution performance to their governing boards on a quarterly basis. And this month, we are now caught up with our fiscal year quarter 3 report for 2025. Here, this report summarizes all cases reported and resolved in fiscal year Q3. Just a quick reminder, when we say all reports, this is including the grievance, the complaints, the concerns, and the compliments. And as you notice, for July and August, the numbers went down, but it's not really a significant drop compared to previous quarter. We've gotten about 7 cases less than most of the cases that we normally have per month. And then also we have 3 vacant positions for patient service coordinators. And we're thinking this might be a possibility of why the numbers have dropped, because we don't have the employees to help take on a lot of the cases. But we're hoping that these vacancies will be filled fairly soon, within maybe the next 2 or 3 weeks, and then the numbers will be more consistent. Next slide, please. So here is another perspective of the data highlighting a positive trend. Grievance dropped about 4 cases per month compared to last quarter. Do we need a clarification of what the difference are, like between complaints and grievances, or we're good?
Directors have any questions about that?
I'd like to see more compliments.
So I would love to be able to see more compliments as well. We get, honestly, we have the Commitment to Excellence Awards, and we get compliments through there. I can start sending those compliments to patient relations and ask them to put that through EMR. But right now, I don't collect those and put them in through patient relations. I keep that for patient experience. Or what I can do is add those to our data, but it'll be through patient experience rather than patient relations. So patient relations is more of the complaint grievance department, and then patient experience is more the patient satisfaction and employee engagement part.
How do we define compliments as definition or criteria?
Usually the compliments are when the patient writes a letter or fills out a compliment card, giving kudos to our staff members or to one of the doctors or the nurses. Yeah.
Yeah, and I would just observe that doesn't mean that they haven't thanked the nurse or said something to the nurse and had built a relationship with the nurse or whomever's they just haven't written anything.
Yeah.
So I don't know how you encourage people to do that.
Yeah. I mean, we also have compliments through Press Ganey as well. When they fill out the surveys, they also put compliments in there too. But we're just not meeting face to face with the patients or reading the letters that are being sent through patient relations.
I mean, it seems to me too, for each of these categories, do we have a sense of what are patterns versus outliers?
Mm-hmm.
And then you can design strategy, based on that. But it may also say what are the things that leadership may want to, on a monthly or quarterly basis, call out to reinforce things that are great.
Is this both inpatient and outpatient?
This is both inpatient and outpatient, yes.
Yeah, maybe you can give people something to check off before they leave about their experience, and you might be able to collect more compliments at the moment they're there, and also, maybe just a scale, a quick scale, 5-point scale.
We don't have like compliment boxes. We should start having that around the sites, and then people could just write it as, we were also thinking there was a technology, kind of like a kiosk for happy or not. As people leave the sites, they could push a button, a happy face button or a sad face button, but we didn't want to, because we want to be good stewards of the funding, we're thinking of maybe just having a box and then having cards at the door for people to just kind of grab the card and put in whether they're happy or not with their service. So there's some initiatives that we are working on so we could capture.
I'm not quite sure why that's so important, collecting compliments, because you have patient satisfaction survey, right? So here, I don't know why we will try to gather more compliments from here.
We don't have to. It's just they. This is just a way for patient relations to keep track of their time and the service that they're providing, because they're just, how do I say it? They're just recording all of the interactions that they're doing in the office. Yeah,
I think what makes it stand out more than anything else is if you look at the number of complaints, grievances, and concerns, they far outweigh the compliments. Seems like we get very few compliments, but we get a lot of complaints, a lot of concerns.
It's dropped a lot.
That's all I can say.
It's actually dropped a lot. Next quarter, I will give you a comparison of what we had the previous years during this time, just so you can see, but we've dropped significantly since.
Yeah, I can speak from my own personal experience. Every time I've been at a hospital, regardless of where it was, I typically felt good about the experience. I felt better, not just because I was leaving, but because of the overall experience.
We'll keep working towards compliments.
Okay.
All right.
I do also want to add that I know she mentioned the press gaining, but we always, we do have a lot of patients who put in extensive narratives and also call out physicians as well as nurses in terms of complimenting the care that they received here. So.
Great.
Yeah, and usually when through press gaming, when I get the names of the doctors or the nurses, we actually write the letters and mail it to their homes as well. So.
Thank you.
Okay, so next slide. Here we have a list of how we receive our feedback from our patients. Just a note, for others, usually that's through social media or a review platform such as Google or Yelp. Next slide. So we have, this is a breakdown of the top 5 categories for grievances. Behavior and respect remains the most frequent reported, signaling an important opportunity for us to continue strengthening our culture of empathy and patient-centered care. This is something that we do monthly open door training for standards of behavior, but then also we do the standards of behavior at new hire orientation so that the new employees know our expectations. However, with our new Chief Clinical Officer, he made a very good point that the staff members have so much on their plate. Going through the whole CI care steps, it could be a burden. So we're going to revamp that whole training and just focusing on 3 things: being kind, courteous, and making sure to communicate always. So we're working on that.
Just one moment, Pat Meriwether, you have your hand raised? Did you have a comment?
I did, and I just wanted to point out that with the Press Ganey, something that's very confusing for many people is that they have 60 days to return the survey. And so even though it, it looks like it's during 1 month, there was an issue, it could have been from 2 months earlier. Because again, it's not tied to the time the patient was discharged. It's just a survey as to the response. So that needs to be kept in mind. And then the other thing is one of the most stressful times for patients leaving in the hospital is when they're leaving the hospital. There's a lot of anxiety. Oftentimes the waits are, waiting for the documents, waiting for the wheelchair to take them out. It's a stressful time. So I would do it a little bit earlier than when they're leaving. I think you'd get more compliments that way.
The other thing too is we did purchase a platform with Press Ganey to do the discharge calls. So within 24 hours, we call. It's an automated system where they call the patient and ask them some key questions, and at the end it says, "Would you like us to call you back?" And if they say yes, then we have another 24 hours to call them back. So they could either call back to complain, they could call back to say, "Hey, I need a referral, please help me with the referral." So right now we're doing the back end of that, and we're hoping to launch that in November.
Okay, I think that would be very helpful. And that's a great service too.
Yeah, and I'm just looking at this and rethinking it, and it would be helpful to provide more context, because the total number, and this is top 5, is less than 100. But out of how many patients? I mean, so the number might be insignificant in terms of the patient volume, because I'm sure we saw more than 100 patients, and so.
So these are grievances that we've had. I don't have on the top of my head of how many grievances total, but I can find that out.
You can just you're looking at like over what period of time are these grievances? What is the patient volume?
Right.
For the
and then
quarter.
that would be the denominator.
Yeah, I mean, because I think that in a broader context, this is a small number. But if you look at it graphically, see this bar way up there says 48, but the number of patients, this is almost insignificant in terms of patients we see.
Yeah,
That's
it's
all.
more than 100,000,
Right.
150,000, right?
I don't know.
That's what
We don't know. That's what I'm saying.
yeah.
That would provide a different kind of context. It's helpful to know these are the most frequent, but they're a small portion of the number of patients we see.
All right. Well, we can bring it back the next meeting.
Yes, I'm taking notes on that. Thank you so much, Dr. Harrington. Okay, next slide, top 10 frequent reported. I don't know if it's mute now with your comment. But parking is number one time-consuming for our staff members, and this is more of a concern because patient would lose their tickets, and then we would help them be able to either waive their tickets or provide like just a $5 maximum for the parking. And then again, we have the behavior respect, accommodation and access. That's something that we're still working on. Most of this has to do with ACHN and not necessarily inpatient. Delay in response, quality of care. The numbers look high, but the truth is it actually has dropped significantly from as we've gone from year to year. Okay. Next slide, please. So this one, it just kind of share the time for resolution. CMS mandates that we resolve grievance cases within, like, at least 80% of our cases within 30 days, and that we send out acknowledgement letters within 7 days. And I'm pleased to report that we have achieved 97% compliance in sending out the acknowledgement letter within 7 days and maintaining a 95% compliance in closing cases within 30 days. The 11 cases that are over 30 days, this has to do more with us trying to resolve either lost properties, lost glasses, or dentures, and so that most of those claims go through downtown, and so that's why it takes a little bit longer. But we're very proud with our team, just the whole staff working together to make sure that we resolve our grievances within 30 days. Next slide.
Before we go into the patient experience, one of the questions I have, what guidance from this, from the board, would be helpful on these topics? It's good to, you're capturing the grievances and the time of resolution, but how can we be most helpful?
How can we be you?
Yeah, what is there any guidance or
No, I
suggestion from us?
think we're doing very well. The director for patient relations, she's amazing. She came from Loyola, and she's running the office extremely efficient, and just being able to resolve these grievances. Before her, most of the grievances would take up to like 100, 130 days to get resolved. So this is pretty amazing to be able to resolve them by 30 days. Yeah.
Thank you.
Thank you. Okay, patient experience. So this is from fiscal year quarter 3, and as you can see, recommend the hospital is coming close to the stretch goal of 76. Next slide. Rate the hospital is trending upward, and we're very proud of our team working together to make sure that just the branding of our hospital is positive, and we've met the stretch goals. I remember Director Harrington was telling us, once we've met it, we should start setting our goals. And so this is something that we have to talk as a team, but we'll figure out with also working with Press Ganey as to what is reasonable for us to set at a higher scale. Next slide, please. Doctor domain scores are still trending upward. They are focusing on the communication, teamwork, and compassionate care. Next slide, our nursing domain. Here we have a star because the stretch goal is actually 76.5, and we're, for August, we are at 76.33.
And are these numbers, if I'm missing something, any different than what was presented earlier under the
So
OPEX
this
dashboard?
one is for fiscal year quarter 3, and the numbers that Donica shared were for just September only, right, Donica?
No, there's a 12-month rolling.
But they're also, these are 12-month rolling too, but yours is for the numbers that were calculated through September, the end of September. And this one is till the end of August, because it's quarter 3 fiscal year.
So the dashboard
June, July, and August, yeah.
So the dashboard is always
It's always delayed, yeah. But hopefully next quarter when we present, it'll be up. It'll be consistent with yours.
So this is a year over year.
Yes. Yep, next slide. This is what the patients are saying. You know, kindness is top on their list. This is through the Narrative DX. It's an AI platform through Press Gaming where they gather all the comments and then they highlight the positive, the things that we're doing well. And then the next slide, it shows you some of the comments that we have of how much our patients truly love our staff, our nurses and our doctors. Employee engagement is the next slide. And then go to the next one with the photos. Just to share some of the employee engagement events. Lots of research has shown that the employee engagement actually affects patient satisfaction as well as patient safety and quality. And so we try to promote and recognize our staff members and celebrate them for all their hard work. And I truly appreciate Dr. Harrington from our last meeting. We were giving kudos to the leaders, but you're like, nope, we also have to give kudos to the frontline staff, which I totally applaud. It's true. Because of them, we were able to be where we are today. And so we, every year, and it's been our culture now because they expect it, but in September, we had the Employee Appreciation Food Truck event. And thank you to Dr. Makaitis for allowing us to make that possible. Staff members had a great time. And then we had 2 community meal paint parties. Unveiling, I'm not quite sure yet because I am due November 7th. So I don't know if we're going to do the unveiling while I'm gone or when I come back in January. And then also years of service. We're celebrating staff members who've been here 5, 10, 15, 20 years and on for their milestone. And the great thing is when I first started in 2021, we only had maybe like 300 or 400 people who met their milestones, but with all the support, HR, revamping how they hire people, the amount of employees who met the milestones were at 1,000. So that's like more than double of people who decided they wanted to stick around and be with Cook County. And then we are having our Thanksgiving and Christmas complimentary meals. And then the next cycle for the Culture of Safety Survey would be January 2026, and Employee Engagement Survey June 2026. We actually had our patient experience retreat shared with all the key stakeholders concerning their surveys, and we've been meeting monthly to have them come to the table and share with us 3 top action plans to help move the needle for the engagement surveys. And so things are going well, so we're hoping since last year, you know, we increased our employee engagement survey by 23 points, and 8 points is considered significant across the nation, and we did it 3 times. And so we're hoping that we'll be able to at least increase by 8 points or more this coming 2026. And that's all I have. Do you have any questions or comments?
Thank you. Appreciate the work in this area. Is there any other questions or info you have for us that would be helpful?
No, not that I could think of right now.
Director,
but I do.
Oh, go
I was gonna say, no, I do appreciate your guidance, and especially, you know, the things that you notice that I don't notice. That's very helpful for me to be able to focus so that we can continue to improve in our patient satisfaction. So thank you.
Okay, thank you.
Thank you.
All right, we'll move to our next item, regulatory update. Would you bet Jessica Pena, Director of Quality Regulatory.
Good afternoon.
Good
Afternoon.
So I'm going to provide you some regulatory updates and some recaps on some recent site visits. American College of Surgeons Trauma Center certification. This is at Stroger, August 12th to 13th, a virtual 2-day survey. We did receive a final report. We have 1 non-compliant finding and what's called 13 opportunities for improvement. We have been verified by the American College of Surgeons, so that's great news. Illinois Department of Public Health dialysis certification. This is at Provident over 3 days, August 18th through 20th. 4 opportunities for improvement or OFIs. I have here, we'll receive a statement of deficiencies within 10 days, which would have been back towards the end of August, and IDPH typically requires a turnaround of about 10 days once we receive the report. I'm sure that's been submitted. I've asked for a status report, and I have not received any notification of that yet, so I will follow up.
On the OFIs, there's a plan and process for those?
Say again, I'm sorry?
On the OFIs,
The plan?
there's a follow-up to the...
Yes, yeah, there's a required follow-up on those. They typically give about 10 business days, so I'm sure it's been resubmitted by now, but again, I've reached out to Dr. Ruiz and have not heard anything in return yet, so I'll follow up again. Next slide. Some upcoming surveys, and keep in mind, when I submitted these, I'll start with this. CAP had not quite happened yet, so College of American Pathologists for Provident lab accreditation, going a little out of order. That did happen this past Tuesday. We had 4 surveyors on site. We did very well. We had 7 deficiencies cited, and we 30 days from the inspection date to submit our corrective actions. We'll tell you that they've already met the next day and have started working on those, so we're well on our way with that. One that still keeps hanging out is IDPH outpatient dialysis recertification survey at Stroger. They were expected back before December of 2024 and still have not come yet, so we're coming up on almost a year, and they're expected at any time. We have the Utilization Review Accreditation Commission for Pharmacy at Stroger. Oversight validation took place on September 15th. We do expect full accreditation, and a report is expected within the next 90 days. I've got IDPH EMS Resource Hospital Site Survey for Stroger, likely early spring of 2026. The National Commission on Correctional Health Care, which is mental health accreditation at CIRMAC, are submitting an application in late 2025 with a goal of a 2026 survey. And lastly, now that CAP is behind us, as far as the site visit, we're shifting gears for a focus on Joint Commission prep for Provident Triennial. It started about 4 weeks ago. And as far as it's an unannounced survey, best guess, we're expecting maybe summer to fall of 2026. That's all I have. Can I answer any questions?
Any questions? Directors online or here? Any input or support we can provide it?
I think we're going ahead strong. Thank you, though.
I appreciate the work on it. Okay. All right. The committee will not be going into closed session today, so if there are no other questions or matters to discuss, we can move to adjournment of the meeting. Any questions, comments, anything to raise? Okay. I'd like to entertain a motion to adjourn.
So moved.
Motion adjourned has been made and seconded. All in favor?
Aye.
Meeting's adjourned. All opposed, sorry. Meeting is adjourned.
You gavel this out. Just gavel again.
There you go.